Thank you. So I'm Nerys, and I'm going to talk today about our experience of following up women who have been diagnosed with B3 lesions in Newcastle. I'm hoping this is going to go well because I've saved my good pants for today. Okay, let's go. So we know that B3 lesions are a family of lesions known to be associated with malignancy, and this can either be at the time of diagnosis, where the heterogeneous nature of the lesions can mean that we have undersampling error if the core biopsy that we take doesn't represent the worst part of the lesion. But we know also that there is a risk over time where it's been shown in published papers that women with these lesions have an increased risk of developing breast cancer, and this is very variable in the literature, more recently sort of said to be 2- and 3-fold in patients with radial scars, for example. But the management of B3 lesions has undergone considerable changes over the past decade, and we pretty much have moved from diagnostic excision for all of these lesions to management with large volume biopsy to establish any coexisting malignancy at the time of biopsy, and then usually some enhanced surveillance over 5 years. So we've been using large volume biopsy to manage B3 lesions in Newcastle, as shown in this chart, since about 2011. And that's very busy, but that's kind of the full chart. But if we simplify it, in this diagram, effectively what we do is that all lesions, B3 lesions suitable for large volume biopsy, after a 10-gauge stereo vacuum or a 14-gauge ultrasound-guided biopsy, undergo a second-line 7 or 8-gauge large volume biopsy, and then are managed according to outcome, such that if it's a B5 diagnosis, they go into therapeutic surgery. If it's a B3 with atypia, they have surveillance over 5 years. And if it's a B3 with no atypia, they return to normal routine recall. And of note, actually, currently in Newcastle, even if the second biopsy, large volume biopsy, returns a B2 result, but with core sites seen, their surveillance is managed along the lines of their worst pathology. So if they've had a B3 with atypia, we would still do 5 years surveillance mammography. So we've kept a prospective database of all B3 lesions since the end of 2011. None of the patients on this database have coexisting cancer diagnosis at the time of their B3 lesion, and the database records the date and result of any subsequent mammograms, any symptomatic presentations that they turn up with, and any malignancy that develops following the identification of that B3 lesion. And follow-up for this presentation is to the end of December 2017. So if we look at some results, we've had 432 patients that had a B3 lesion identified on core biopsy. As expected, the majority of these were screen detected, but there were 50 who had presented through the symptomatic result, and the age range of these patients spanned from 15 to 84 years, which was a little surprising. 346 patients underwent a second-line large volume biopsy, which is 80% of our cohort. And 86 patients had either a diagnostic surgical excision at pathology or radiology request because we couldn't do a large volume biopsy for whatever reason, or they declined any further repeat biopsy. 51 of our 432 patients were upgraded to malignancy. 33 of these were upgraded following a large volume biopsy, and 18 were following diagnostic excision. And that gives us an upgrade rate to malignancy of our B3 lesions of 11.8%. And all of the remaining 381 patients have been followed up either as part of the screening program on usual 3-year yearly mammography, or on a 5-year program of annual surveillance mammography, which is part of our symptomatic service. And these patients have had 633 mammograms performed between them to date over a follow-up period of up to 5 years. So 78 patients from the cohort have needed further investigations during the follow-up period. 29 have been recalled from mammography for further assessment, which gives about a 4% recall rate. 47 patients, interestingly, presented symptomatically with a variety of things, I have to say mostly breast pain, and 2 were discovered as needing further investigation from high-risk MRI. They were having high-risk MRI for radiotherapy below the age of 30. So we've had 16 cancers identified to date. Both of the high-risk ladies on MRI had a positive biopsy for cancer, 4 following symptomatic presentations and 10 following recall from surveillance mammography. And actually of note, just for a kind of a workload sort of figure from this, we did subsequently also diagnose 13 further B3 lesions in this cohort and 48 benign diagnoses, mostly fibroadenomas. And so if you just look at the group, that the rate of future cancer development following a B3 lesion for this cohort is 4.2%, but actually it's 3.7% if you exclude the 2 high-risk women who probably shouldn't be considered in this same category, but I've kept them in for completeness. Of the 16 cancers identified, 10 were ipsilateral, but only 6 were at the original site of the B3 lesion. There were 14 invasive cancers and 2 were DCIS. Sorry, this is busy, but it just shows all of the cancers which developed over the follow-up period. And if we looked at the early cancers at 1 year, 2 were at different sites to the index lesion, and 2 were in the high-risk MRI women. In one of those women, it was actually at the same site as the previous B3 lesion, which we reviewed and felt possibly did represent some undersampling of the initial lesion, but fortunately she was picked up on MRI. 12 of the original B3 lesions who subsequently went on to develop cancer were B3 lesions with atypia, but this isn't exclusively occurring in B3 lesions with atypia. There were 4 lesions without atypia who did subsequently get a carcinoma. So if we look at it as a survival analysis, you can see with the follow-up available to date, we can calculate a risk of subsequent malignancy in patients with B3 lesions at 4 years to be 12.1%. Obviously, the statistics on that will get tighter as the cohort has more follow-up, and that will be interesting to see with time. So in conclusion, B3 lesions do identify a group of women with a risk of subsequent breast cancer, but the magnitude of this risk is small, with less than 4% of this cohort progressing to cancer to date if the high-risk women are excluded. Furthermore, follow-up with annual surveillance mammography has a very low recall rate, but it does have a significant cancer detection rate. But we do also need to remember that only 2/3 of the subsequent cancers in this group did present on surveillance mammography. And what we've also shown that as a group, following B3 diagnosis, they do have a really high rate of symptomatic attendances. 20% of them came back for other complaints, and which is suggestive that, telling a lady that she's got a B3 diagnosis is actually quite anxiety-inducing for some women. So as such, I did wonder if we should begin to question whether such surveillance strategies are cost-effective, or actually all we're doing is kind of following up the women that were going to get a screen-detected cancer within the screening program anyway, and that maybe we should start to acknowledge that for most units, the cancers which develop in these women with B3 lesions are mostly then identified following surveillance mammography, which is performed as part of the symptomatic service, and it's possible that over time this may start to affect a unit's screen-detected cancer statistics. Or alternatively, if we feel that the cancer risk in these women really does warrant an enhanced screening surveillance strategy, is this a way to identify a set of women who really could be offered, our first type of stratified screening as part of the National Breast Screening Programme, so that we could offer them 18 monthly mammograms instead of our usually 3 yearly screens? It was just open for debate. Thank you.